Hi everyone, today we'll be discussing about retinitis pigmentosa. Retinitis pigmentosa is one of the hereditary retinal dystrophy or hereditary fundus dystrophy. So, it is the most common fundus dystrophy, which predominantly affects the photoreceptors, in that mainly rods, and later on even it involves the cones also. And inheritance patterns, it can be autosomal dominant, autosomal recessive, X-linked recessive, and in some cases even sporadic. Coming to the mode of inheritance, like I told you, it can be any of these X-linked recessive, autosomal recessive, dominant, and sporadic. Autosomal recessive and X-linked recessive are thought to be very severe form of retinitis pigmentosa. So, if it is through this inheritance, then they present it at a very early stage, and the result, it can lead to complete blindness by as early as third to fourth decade of life. Whereas autosomal dominant has generally a better prognosis when compared to the other forms, and sporadic also has a more favorable prognosis when compared to autosomal recessive and X-linked recessive, with the retention of central vision until the at least sixth decade or later. So, since it is a dystrophy or hereditary dystrophy, which is involving the main photoreceptor cells, that is rods and cones. So, and I told you predominantly in the initial phases, it involves mainly the rods. So, the initial symptoms when they are presenting, it will be with nyctalpia or defective night vision. So they come with the complaints of defective night vision, and sometimes difficulty in seeing in the night or glare. So this is the most common presenting symptom. Okay. So, and later on when it advances, uh, in the third or fourth decade, fifth decade, they might have a complete blindness, because uh, initially it involves the rods, and later on it can involve both the rods and cones. So it can lead to mid-peripheral and peripheral loss of vision. Why? Because rods are concentrated more in the periphery. Since it is involving the rods initially, so they can have a preserved central vision, but the mid-peripheral and peripheral vision field loss can be there. And later stages, like I told you, it can lead to reduced central vision, and it is commonly associated with cataract. Coming to the signs of RP, so this is the most commonly asked question in the Viva: what is retinitis pigmentosa and what is the Triad in retinitis pigmentosa? You need to remember this. So it has a classical triad of bony spicules or pigments along the mid-peripheral vessels, okay, as well as peripheral vessels. So this is called bone spicule. Okay. So, and next important sign is arteries will be narrowed, arteriolar attenuation, and the third sign is waxy pallor of the disc. It is nothing but because of secondary optic atrophy. It is called consecutive optic atrophy, that is secondary to some retinal pathologies. It is called consecutive optic atrophy. So this is a classic triad of RP. One is bone spicules, that is nothing but pigments along the vessels, along mainly the arteries, arterial attenuation, and waxy pallor of the disc, that is optic atrophy, which has a waxy pallor. So coming to the progression, so initially it starts with bilateral mid-peripheral intraretinal, that is within the retina, perivascular along the vessels, bone spicule pigmentary changes with arteriolar narrowing. Then a gradual increase in density of the pigment starts. First it starts off in mid-periphery along the arteries. Then there will be gradual increase in the density of pigment, extending both anteriorly and posteriorly. Then peripheral pigmentation will become more severe with marked arteriolar narrowing, and finally it will lead to disc failure. So this is the course of retinitis pigmentosa. So this is the picture depicting the signs of RP, like what I have told you. You can see this is the initial stages where you can have in the mid-periphery of the retina there are pigmentary changes. So this are nothing but they are called bone spicules along the vessels, along the arteries mainly, and like you can observe, you won't be able to make out, but there is a gross arteriolar attenuation. So the bright color reflex which you are seeing, the broad vessels, they are veins, and just adjacent to that the other vessel are arteries. Okay, so they are grossly attenuated, and in later stages, in this picture you are not able to see the disc pallor because this is the initial stages. So in later stages you can see waxy pallor of the disc. So this is a classic triad of RP or retinitis pigmentosa. And sometimes the macula can also be involved. So you can see macular atrophy or cystoid macular edema or epiretinal membrane formation in the macula, and usually they'll be associated with myopic refractive error, and very rarely you can see a optic disc drusen. This is not important, but just remember they can be associated with some macular involvement also, and some refractive errors like myopia. So actually these are not complications of retinitis pigmentosa, but all these are associated associations of retinitis pigmentosa. Usually retinitis pigmentosa patients may be associated with posterior subcapsular cataract at an early age, then open angle glaucoma, keratoconus, then very rarely all this posterior vitreous detachment, intermediate uveitis, and exudative RD. So these are the associated features of retinitis pigmentosa, mostly posterior subcapsular cataract, open angle glaucoma, and keratoconus. So retinitis pigmentosa doesn't need any investigation because it is clear cut. Clinically you can clearly diagnose it. So the symptoms and signs are classic in case of typical retinitis pigmentosa. So, but rarely to know the prognosis or to know the severity, how much of the retinal function is lost, and occasionally we need to do investigations like electroretinogram, electrooculogram, perimetry, OCT, and if required, genetic analysis. This is a picture depicting electroretinogram. So electroretinogram, it is nothing but like ECG of the eye. Mainly tells about the retina, layers of the retina, functions of the layers of the retina. So it has three waves in ERG: A wave, B wave, and C wave. A wave depicts the photoreceptor function. B wave depicts the Muller cells and bipolar lens function, and C wave depicts the RP function. So in case of retinitis pigmentosa, E wave is grossly affected. So like I told you, ERG is a very sensitive test. So in early stages, even in that you can make out, in the A way you can make the photopic and scotopic. There are different test cycles in the ERG, like photopic response, scotopic response. So in early stages, only the scotopic responses are reduced. It is because it's mainly because of rods, and with later stages when there is a progression, there is reduced even response in the photopic responses as well. So and if perimetry is done, a classical ring scotoma is seen in retinitis pigmentosa. So it's mainly because of involvement of the peripheral retina initially, and the sparing of the central retina. You can see a ring scotoma. Okay. So it starts as a group of isolated scotoma around 20 degrees from the fixation, and gradually it progresses to form a partial followed by a complete ring of scotoma. So it is useful in monitoring the progression of disease and document the status in legal blindness. So that's the reason why we are doing perimetry. So to monitor the progression as well as to document in case of legal blindness. If we have to provide certificate to the patient, we need documentation. So that's the reason we have to do perimetry. So coming to the treatment of retinitis pigmentosa, many treatments have been explored with very uh, poor benefit, like without no proven benefit. It's not so they include various like vitamin A, mineral supplements, vasodilators, tissue therapy with the placental extract, cortisone, cervical sympathectomy, and many others have been tried. Even subretinal injection of fetal retinal cells. So all the modalities have been tried, but with very poor result. So till now, till date, there is no proven treatment for retinitis pigmentosa. So once the patient is blind, the patient is blind. So we can just give them a low vision aids or low for the if the patient is having doesn't have a complete loss of vision or a difficulty in night vision, so we can provide him with low vision aids. So otherwise, there is no definite treatment for retinitis pigmentosa. In retinitis pigmentosa, you have to know something about atypical retinitis. Till now, what all we were speaking is everything about typical retinitis pigmentosa. So there are a few entities called atypical retinitis pigmentosa. In that, one is syndromic and another is non-syndromic. So in syndromic, it is involved with other multisystemic disorder or syndromes like Usher syndrome, Kane-Sarry syndrome, Basin-Cornet syndrome, Refson syndrome, Barrett-Weedel syndrome. So retinitis pigmentosa can be associated with all these syndromes, and in some non-syndromic, so ideally I told you typical retinitis pigmentosa present with a classical triad of three signs. So in non-syndromic atypical retinitis pigmentosa, you will see atypical presentation of retinitis pigmentosa. It could be a segmental, it could be different color of the bone-spicules or lack of bone-spicules in view. But it is also a type of retinitis pigmentosa. In these, sometimes we might need some electrophysiological testing. So coming to Usher syndrome is one of the common is one of the syndrome which is associated with retinitis pigmentosa. So in this there are three types. Type 1 being the commonest, and usually Usher syndrome is associated with hearing loss. So type 1 it is associated with profound congenital sensory neural deafness with severe RP, which presents as early as in first decade. Whereas type 3 it is also associated with retinitis pigmentosa, which is very rare, like it accounts only for 2%. It also presents with a progressive hearing loss and relatively late onset of retinitis pigmentosa compared to type 1. Other syndrome which is associated with RP, that is Bardet-Biedl syndrome. So it also has some typical features like which includes retinitis pigmentosa, mental retardation, polydactyly, apple-shaped obesity. So obese child with polydactyly, with mental retardation, with hypogonadism, with RP. So these are the signs of Lawrence Bardet-Biedl syndrome. So almost 80% have severe changes of retinitis pigmentosa by the age of 2 years. All these syndromes are associated with mostly early retinitis pigmentosa. So other syndrome which is associated with retinitis pigmentosa is another disease, not a syndrome, that is Refsum's disease. So Refsum's disease is in which there is exogenous phytanic acid accumulation within the cells. So it has other features other than RPR, peripheral neuropathy, ataxia, and an increase in CSF protein with a normal cell count. So all have elevated serum phytanic acid. So this disease is also associated with retinitis pigmentosa. So coming to non-syndromic atypical retinitis pigmentosa. So till now the three diseases what we have discussed were syndromic atypical retinitis pigmentosa. So now it is atypical non-syndromic retinitis pigmentosa. So the name itself suggests. So one is retinitis pigmentosa sin pigmento. Sin means without pigment. It is retinitis. Retinitis pigmentosa means as soon as you hear the name, it means that bone-spicules, a triad of bone-spicules, arteriolar attenuation, and waxy pallor of the disc. So, but if there are no pigments, but it is still a retinitis pigmentosa, but there are no pigments, then it comes under retinitis pigmentosa sin pigmento. That is absence or paucity or less pigmentation. So may subsequently appear with time later on at a very later stages. They can show pigmentation and functional manifestations are similar. So all other symptoms will be similar to retinitis pigmentosa as well as other depicting. This is a picture depicting retinitis pigmentosa, sign pigmentosa, where there is gross retinal dystrophy, like retinal arterial attenuation and failure of the disc, but there are absolutely no pigments. Other atypical retinitis pigmentosa, that is retinitis punctata albicans. The name itself indicates albicans means something white. So here usually these bony pigments or the pigments, they are black in color. Bony spicules or pigments are black in color, but albicans in retinitis, this one punctata albicans, you will see a whitish specules. So they are scattered white yellow spots, almost numerous at the equator, and usually sparing the macula with other signs like arterial attenuation and pallor. So similarly, the functional changes are similar to retinitis pigment. Only thing is the pigments, instead of black, they are yellowish white in color or whitish in color. So this picture depicts retinitis punctata albicans, where you can see yellowish white pigments when compared to typical retinitis pigmentosa, and other signs are similar to typical retinitis pigmentosa. So other signs, so similar to other atypical retinitis pigmentosa. So there is something called sectoral retinitis pigmentosa. The name itself suggests here you have only a sector of the retinal involvement, and it is usually autosomal dominant inheritance and characterized by involvement of mostly sectors, that is most commonly inferior quadrants of retina. The progression is very slow and may and many cases are apparently stationary. They appear and they don't progress. They remain stationary. And there is something usually retinitis pigmentosa is a bilateral condition. It's never unilateral condition, but rarely unilateral retinitis pigmentosa can also occur in case of sectoral RP. So this is a picture depicting the sectoral retinitis pigmentosa, where you can see pigmentary changes, arterial retination in only one sector. The most commonly it is a inferior sector.